Okay,
Says it's being recorded.
all right. Guess we'll get started. Have we all met each other at this point? Solimar, have you been to a,
Not in
in-person meeting?
person. That's my first in person.
Oh, that's,
But I do. Yeah,
yeah,
started, but I faces.
good. And we've got our name tags. We can,
Turners.
oh, I was helping myself. Good. Well, I'm so glad we're able to get together in person and meet you directly. That's great. So we'll start with looking at the minutes from, I believe they're from September 12th. So if I could have a motion to accept the minutes.
Make a motion. Oh, right. Just one adjustment. It says I was excused. I was at the.
Oh, Okay, with that correction.
And sorry, I was excused. My name does not appear.
Okay. Sheila was present and Elise was excused. Okay, so I think we still need a second for
Second.
us. Any other corrections or additions? Okay, all in favor of accepting the minutes? Okay. They are passed. Thank you, everyone. Going to any correspondence or announcements? Anything anyone wants to bring up or announce? Okay, good. And I don't have a specific report, so we could go directly to Harmony.
Okay, great. Thank you so much. As you know, last time when we met, we talked about the local services plan. So a lot of work has been done by the subcommittees in regard to putting that plan together. So I'm going to share my screen and go through a little bit of a PowerPoint with you. I want to welcome our guests, David, Diana, who you see on the screen here with Stu and myself. David works for a local agency, and I'll get into an introduction for him in just a few minutes when we get to the slide. He's going to be an expert, a content expert for us, and talk about the workforce shortage so that you have a real good understanding of how the workforce shortage is really impacting some of our more intensive services in the community. And also, I think it's a great opportunity for you to get to know David a little bit better, because I don't think he's ever presented or come to one of our board meetings before. So wanted that opportunity. So I'll get to introducing him in just a minute. Also, Rich Shaw is with us today. Rich came and spoke to you a few meetings ago, I believe, when we were talking about integration around mental health and substance use and the importance of treating co-occurring disorders. But tonight he's going to be our content expert as our SPOA coordinator, talking about housing shortage in our community, the gaps in services for people in that area. And Elise, our own board member, and Elise is going to be talking with us a bit as well in her area of expertise and some of the particular needs in the developmental disabilities department around care and services that are lacking. Really, it feels like we already had challenges, and since COVID, it just has really brought to the forefront some challenges and made a lot of things more difficult for us. So this plan really is going to work on prioritizing those particular needs. So having some people talk with some content expertise about it, I think is helpful for you to hear the whole process. The end product for tonight, we'll get to the objectives and the plan. And if you're a guest and you're virtual, David, you do not have to stay for the end product. You can leave whenever you feel that you want to, or you can stay if you would like. Until we get to a section where it's just board members, but that's announced. We will go over all those objectives that you see in front of you in paper form, and you also should have had them sent to you electronically today. That's ultimately the plan. But the slides will show you how we got to the plan, and the goal tonight is to make any changes that you think are necessary, finalize our plan if it seems appropriate to you, and vote on it. And if it passes, then that will be submitted to the state for our plan for 2023. We have until October 31st to get our plan here. This is our last board meeting before that. So in an abbreviated plan that started in September to October 31st, we lost almost a month additional time, but our subcommittees did some extraordinary work this last month in putting this plan together. And so you'll see a lot of their ideas here. And I'm sharing my screen. Do you see my screen?
Not yet, no.
Not yet.
Okay. My apologies. It's using a different format than I normally do. And so now you probably see a tiny one, and I'm going to make it bigger. How's that? Do you see something now?
Yes.
I'm just going to keep the slides on the side, because one of the tricks I've learned is if I do that, I actually get to see some people's faces while I'm going on. If I give you a full screen, I lose everyone's face. So at least I feel like I'm talking to somebody when I'm doing this. So the local services plan, of course, is designed to build a stronger mental hygiene system in Tompkins County. Every county is required by law to create a plan every year. And the goal is to really make sure that we're addressing as a board and through our subcommittees, really addressing the biggest issues in our community to make sure that we have adequate services and supports for everybody. There are 3 steps really to this abbreviated plan this year. It's identifying our needs and priorities, which is what we typically do in a regular year. But this year, there's been this addition of supporting health equity. And there was some work we did and just identifying where people are at in our community on health equity. In particular, racial equity is the area of focus that the Conference of Local Mental Hygiene Directors and partnership with the state agencies, so OMH, OASIS, OPWDD, and with some volunteers, Director of Community Services, but before my time, so I couldn't volunteer to be on this committee. They worked very hard to put a plan forward, and we'll talk a little bit about what that plan is. And the hope is that this will start getting counties to think about the importance of health equity work, racial equity work, in particular for this as the first starting point in such a broad topic as health equity. How can we make sure that people in our community have access to all the services, and that we don't have discriminatory practices or practices that may create a sense of people are not welcome in our place, whether they're subtle. We want everyone to be welcome and able to receive services. So we'll talk a bit about that. That's brand new. This is the first year where that's talked about. And then setting our goals for the next year. And then within that, we have some pretty clear objectives and deliverables of what we hope to accomplish in the next year. And it's a big plan. And it's okay if we don't get to everything. We can look at what we want to do in the next year. The reason the plan was abbreviated this year, we normally start the process in March, and about September, we have the plan submitted to the state, they review it, and then we have a plan by the beginning of the year. That it was abbreviated this year because there's been a lot of work being done to change from an annual plan to a 4-year planning model, which really makes a lot of sense. We look at these goals. These are not things that you can easily see change and address in a year's time. So there's been a lot of advocacy around from counties and things to really change this plan into a 4-year plan, and that was listened to. So 2024 will be the beginning of the 4-year plan. So when we start thinking about what do we want to do in 4 years, we're clearly going to want to spend a lot of 2023 really putting a solid plan together that will address our needs over a 4-year period of time. It'll have to be a more complex plan. So we'll probably start working on that early in 2023 for 2024. So it feels like a lot of planning. So this is really a stopgap plan and it's required by law. So, but it still has a lot of value and there was a lot of hard work that went into creating this plan. The plan's informed by the state. I showed you this slide before, so you have this, but basically what this slide talks about is the importance of our plan being informed by what the state's priorities and their plans are. So each of the state agencies released about a 10 or 12 page document that you all received. So they're pretty easy read. I got to say OASIS plan to me is the easiest because they say, here's our goals. Now we'll tell you why. And they really go 1, 2, 3 in their plan. But all of the plans are really good. And here I tried to pull out what I thought were the biggest things that each of the plans were looking at from the state's perspective. So the state informs our work. And you'll see crisis services, that's across all of them. Coordinating services across all of the 3 state agencies is on the plan. There's goals of making sure that peer supports are recognized, valued, and enhanced across different programs. So you'll see workforce infrastructure is highlighted in all of them. So there's a lot of areas where you'll see all of the state agencies feel are important things to address. So it's helpful to know that. On the top of the slide, and I showed you this before, but you got a lot of information, so it's probably worth repeating it, is that the state takes all of the local services plans, and when they get this new version, they're going to be really happy because it's going to be much better design, and instead of having to count things by hand, or however they count them now, it's going to actually tally information for them behind the scenes. So they'll have better data collection in the 2024 plan that will really give us better information. I think they'll be able to inform us better what all of the counties are saying. But right now they take all of the information from the counties that they get in their local service plans and they look for patterns, like what kinds of issues do a lot of counties have in common, and then they also look for what are the issues that cross all of the different O agencies, and that's going to inform their planning work because they want to focus on the things that they see a lot of counties are struggling with across the system. So workforce recruitment last year in 2022, 26 local government units like ours focused on that. Housing was the next with 24, crisis services with 23, and transportation with 20 different counties identifying them that were impacting most of the time in those numbers. It was all 3 mental hygiene systems, OMH, OASIS, or OPWDD. There's a beautiful chart that's inside of the plans that you have that spells out, well, it was, you know, out of the 26 LGUs for workforce recruitment, 20 of them, it's across all mental hygiene systems. They have it mapped out for you in the specific detail if you want to look there for that. But generally speaking, these are the big problems that communities are facing, and not just us. So that information informed our work in this plan this year, but so did local knowledge and experience. So Rich is going to talk with us for a few minutes here about housing needs. And Rich, as I believe most of you know, he is our coordinator of dual recovery and the single point of entry for Tompkins County Mental Health Services. And Rich has a social work degree, and he also, and I apologize, Rich, you have a CASAC, and I don't have that on there, but I did want to acknowledge that in your dual recovery role, you have both of that background in training and expertise, and really that single point of entry for Tompkins County. Your work is really seeing some of the most challenging situations for people who are struggling in our community, and what you come up against, you know, day in, day out on the housing needs, I think is important for our board to hear. So I hand it to you.
All right, thank you. Yeah, I was just looking over some of my notes, and David can certainly talk more about the programs and get into great detail about the different kinds of housing that are in our county. But I was looking, every county has to have a single point of entry or single point of access coordinator. And what that means is there's other things that person does, which is me in this county. But one of the things we do is we look at applications for people with serious mental illness, because they are and that is defined by the state with serious mental illnesses. And they have special housing made available to them. Most of that housing is provided by Lakeview Health Services, so I'll defer to David to talk more about that. I've been in this role for 13 years, and where it stands right now is this, I run a committee, the Single Point of Entry Committee. We meet twice a month, and what we do is we review all applications for people with serious mental illness in Tompkins County who are looking for housing. And on average, we get anywhere from, I would say, it's pretty steady. I've never seen like a lull in a month. Like we may have one meeting where we have 2 or 3 applications, but typically we have 5 to 10 applications twice per month. So about 10 to 20 per month. 20 would be a little high. I'd say about 15 is a typical number per month. Like I say, there's never been a lull in applications all year round. We get applications. And I was looking through some of the numbers, and you know, the one that I think is most striking is how many people are on. We create a list for each of the types of housing, and people stay on that list until they're actually housed. And so part of what the Single Point of Entry Committee does is just help watch people from the time they put an application in until the time they're actually housed. And right now, if you look at all the housing that the Single Point of Entry Committee takes applications for, there are 60 people on the waiting list. And that may seem like a lot, but that's one of the lowest numbers that I've seen in the 13 years that I've done this. So the bottom line for me, when I think about Single Point of Entry and the housing for people with serious mental illness, is that we don't have enough of it, and the people wait on the list for long periods of time. I can't think of a person who's been housed in less than a month's time. So people who are on the list are typically in great need of housing and need it soon. Some are actually homeless. And they have to wait for quite a bit of period of time, because it's not a simple process to have somebody screened and accepted into the housing that people are applying for. But so people, one of the things that happens that I've seen over the years that is not unusual is that somebody will be on the list and will be on the list for so long that we can no longer reach them. So people, you know, change phones, or they start to live with somebody else, or they move out of county where they have a place to live temporarily, or maybe permanently. But so people on that list are sometimes lost to contact, where we don't know what has happened to them. So those are the major points I want to make, is that we always have a steady influx of applications. I'd say 10, 15 per month, as many as 20 per month. The waiting list, there's always a waiting list for each program. And even though we have 60 people waiting right now, that's a pretty low number. It's gone up much higher than that. It's low now because we're trying to be very diligent about making sure that the lists are up to date, and the people are moving through the system as quickly as possible. So I'll leave it there. If anybody has any questions.
I have a question. What is the age that you serve, that Lakeview serve?
So adults 18 and older. And sometimes people will apply before they reach age of 18. In different counties, we have guidelines of how this process should go, and we're pretty, we try to really make sure that we do everything we can to house somebody. So if I get an application for somebody who's not yet 18, we hold it, we stay in contact with the referral source. And then we move ahead with it as soon as they turn 18. So we hold on to those. We don't reject them and say the person's a minor. We will stay in contact with the referral source. And I guess that's one more thing I'd mention is, where do people come from? Many from our local hospital, the psychiatric unit. When somebody's about to be discharged, they're not being discharged necessarily into stable housing, or the state psychiatric hospitals, which are Greater Binghamton Health Care Center and Elmira Psychiatric Center. Other referrals are sometimes people self-refer, and sometimes it's a family member. And it might be a mental health treatment provider or a substance use treatment provider.
I have another question. When you say that they have to qualify under New York State guidelines, is that something that once you guys meet with the participant, you guys decide based on your guideline, or do they have to go through another application process with the state?
Yeah, that's a good question. Basically, we need some, part of the application process, we need some confirmation that somebody has assessed them and that they meet that criteria. So typically, it's a treatment program that has done a mental health assessment and is saying this person meets the criteria. There's an actual form with all the criteria and somebody signs off on it. A licensed professional typically will sign off and say, yes, this person has a serious mental illness as defined by these criteria. In the event that that does not happen, we don't have that information. So the shelter may have people where they say, listen, person, from what he's telling us, has a long history of hospitalizations and has a mental illness. We have to get that person connected to we either need records or we need to connect them to someone locally who can assess them and give us some up-to-date information that confirms that. Otherwise, it really creates problems in the referral process because Lakeview can't take somebody and then, figure out later that the person has serious mental illness. So we need to do that up front. And we work with the person as much as we can, as much as we need to help them get what they need. So for example, if somebody's at St. John's Shelter and St. John's is like, we want to fill out an application, but we don't have any background on this person's mental illness, we will work with them to get the person to Tompkins County Mental Health, get an assessment that will be put with the application, and we'll move forward with it. So that happens fairly with some frequency. It's pretty regular where we need to get that in place for the application.
Any of the new construction available to you at all?
Which,
Well, the building, seem to be building housing all over the county. And is any of it available to you at a price that's reasonable?
well, I would leave that to David to talk about. So the most independent level of housing is referred to as supportive scattered site, and that those aren't apartments that are already designated for this housing. So what Lakeview does is works in the community to secure housing, apartments in the community. So it may be in some of the newer places. And there was just a brand new project, West End Heights, that was built, which is mixed use housing, which was really important for our county, but also as noted with the waiting list, it's full now and we still have a pretty big waiting list.
That's why I asked the question.
Yeah.
More of it.
Yeah, Rich, how often do the same folks come up on the list? Do they come on it and off it, or is it always a new group of people who are?
It's a mix. Sometimes many of the people on the list are known to those of us who meet together. The single point of entry committee is comprised with a number of agencies, Unity House, Lakeview, Tompkins County Mental Health, the ACT team, the sort of community treatment team is on the committee. And so there are many people that we know and are aware of, and for various reasons may need housing at different times. So we do see people. So somebody may end up in Greater Binghamton Health Center who's been out in the community and we haven't heard from in a long time. They're recovering and doing well. And then coming out of Greater Binghamton Health Center, just use as an example, a person may no longer be welcome back to where the person was renting. So Greater Binghamton puts in an application for us and we try to help the person again. They get, that person will get top priority coming out of state psychiatric facility, but still, housing only moves as fast as it moves. And so it may take some time. So sometimes the hospital's like, we need to discharge this person soon. He's ready to be discharged and we have to say on occasion, not so fast. We have to get the housing in place if he needs housing.
Sure. Questions for Rich? Yeah. Back to you, Harmony.
Okay, thank you so much, Rich. I think that was really informative. One of the comments that somebody made on one of our subcommittees when we were talking about housing, which I thought was really thoughtful. I think it was somebody from Reach. They were saying, we have to look at housing and the different types we need. because people cannot be successful if they don't have all the supports wrapped around them, right? Like we need these specific kinds of mental health housing and housing with connections to supportive people. And also they were saying for people who are homeless, generally speaking, it's very hard to transition directly from homelessness to housing and say, well, that's great, that's all they need. You know, people who really struggle, they've probably experienced an enormous amount of trauma, if not before, since they've been unhoused. So it's they say we don't need just affordable housing in our community. So we need to make sure that it's out there when people are talking about housing, that we need specialized kinds of housing to meet the needs of the people who are most vulnerable. So I'm going to now pass it on to David Diana, and I'm going to read an introduction about him so you know who he is. Rich referred to him a few times, so Rich clearly knows David quite well. David Diana is the Managing Director of Residential Services for Lakeview Health Services. He has been in his role as Managing Director since 2012 and is a licensed mental health and credentialed alcohol and substance abuse counselor. David has been in the mental health field since 1984 and has worked in a variety of settings as a direct care residential counselor, case manager, care manager, mental health therapist in a county mental health clinic, and has supervised clinical social workers and case staff and a comprehensive co-occurring county outpatient clinic. So David brings a lot of wisdom today, and I'm sure you might have some housing questions for him as well, but he's also coming to talk with us about workforce recruitment and retention and the big challenges we're experiencing in that arena. Thank you, David.
Sure. Thanks, Harmony. I appreciate the introduction, and thank you for inviting me here tonight. I think most of us realize how COVID has impacted many industries across our counties across the state, but it also has impacted the mental health field substantially. We see it particularly in residential, where, excuse me, a number of programs were really impacted. We had one program that was impacted so severely that I had to pull staff from other departments within Lakeview to be able to house and maintain the 24/7 program. That was not in Tompkins County, fortunately, but we do experience the difficulties in terms of staff shortages. And I think COVID has gotten people to think about other opportunities and not to work in the mental health field, unfortunately. And so how do we recruit? Prior to COVID, I was going around to the local colleges, Ithaca, Cornell, as well as TC3, and I was able to recruit individuals to work in the Tompkins programs. We haven't been able to do that because of COVID. And so that's a huge drawback in terms of being able to, to take a staff person who's worked in our program with me, who has a number of years of experience and really started out working in direct care work while I was in college. And then went through the whole continuum of care within the mental health system. Really gets people to think about that. And we were able to recruit a number of college-age students that stayed with us 2, 3, 4 years through their 4 years of education and then beyond that. And so that is lacking there, that we can't do that type of recruitment. We've done a number of things to try to attract people to the field. In particularly in residential, we've created a $4,000 sign-on bonus for people. We've looked at people referring people to give them a $2,000 bonus. These things have helped to stir a little interest, but still we're lacking. And part of it has to do with the COLA that residential programs have not experienced 11 out of 13 years of no cost of living increase. So this past year's budget was substantial, where a 5.4% increase occurred, which has been very helpful, and be able to retain perhaps our current. We're still having difficulty recruiting individuals to come work in the field. And so I'll give you an example. And many of our residents of Tompkins County have taken advantage of our crisis respite program. We were one of 12 programs across the state to be part of a pilot back in 2015. That program went very well. We got wonderful reviews. Individuals were able to stay between 5 and 7 days, short-term stay. Rich talked about individuals needing to be released from the hospital. That would have been referred to as a step down program, where we could take them into the crisis respite before they actually go into their permanent housing. We have not been able to fill those positions. When the manager left that program, the staff that was on were dispersed to other programs within residential. And I have not been able to recruit individuals interested in working in a crisis program. That program's been closed since May 27th of 2021. That is a substantial impact in the 6 counties that we serve, and Tompkins being one of them. So those are things that I think add to the challenges that we face as we try to look at better ways to recruit. I think we're trying to put together initiatives, for example, for staff that work that 3 to 11 shift, which is very difficult. What happens usually is people get the job for the first time, maybe right out of college, right out of the community college, and they take those evening shifts. And then when they get the experience, they move into a day shift, which leaves those evening shifts with really new, professionals. So what we're trying to do is put in an incentive on that evening shift to encourage people who have years of experience to stay in those evening shifts. So we've just started that at the tail end of September here, and hopefully we might see some people interested in that because they're going to get an increase in their hourly wage. It's called a shift differential for that evening shift. We do that for our Wake Overnight because almost all of our programs are 24/7 programs. So we need to have staff 24/7 as required by regulations and in terms of providing the services of care. The wonderful thing about Tompkins County is that you do have the continuum of care of housing that we provide at Lakeview. So you have the community residents, and the handout that I gave kind of talks about that. That's the Markham CR, community residents. And that's a 14-bed program where individuals who really need additional assistance, many individuals really meet the criteria in terms of diagnosis around schizophrenia and schizoaffective disorders. So they need a lot of support to get them, to move them along the continuum to which is the next level, which is the treatment apartment programs. In Tompkins County, you have West End Heights, what was referred to. That's a single site program that has 20 licensed beds within that are available to the residents of Tompkins. And then you have the scattered siter programs, which also is an additional 21 beds spread throughout the county, where we lease those apartments through local landlords and work directly with them to ensure that they meet the code and any concerns that maybe the residents may have with those particular apartments. So all of those programs move along the transitional, referred to as transitional housing. It's not permanent housing. It allows them to learn and get the skills necessary so they can move on to the next level, which would be our supportive program, which is run by Ashley Keiss, where those individuals would be able to have more independent living in the community, but also have the support. One of the goals that we have in residential is really to connect, and Harmony mentioned this about having wraparound services for individuals so they can be successful, is to have services through care management as well. We're trying to get about 50%. Our goal with the state that we set up with them over the next, we're into year 2 now, so the next 3 years is to have about 50% of our residents engage in some form of care management. So that wraparound service can help them as they move on to the next level of care as well. So it's been a challenge to be able to recruit. It's been a challenge to be able to retain. I think we've been able to retain our current staff. During COVID, I spent pretty much 4.5 months down at the SRO because we were without a manager there. And I called the staff there the Fab 7 because we really maintained that program of 38 beds, which are the most vulnerable population at the single room occupancy there on 3rd Street, because many of them are aging in place. And so they were the most vulnerable population to actually, attract COVID. And so that core group, but imagine that, just the 7 of us and myself trying to maintain that over the course of 4 to 6 months was very intensive. And so what it creates also is it creates our staff having a number of concerns as well, their own mental health and the ability for their wellness. So not only the data that I shared with you in the handout really looks at the retention issue across the state at averaging about 28% where occupancy rate. We have some regions in New York State that are up to 40% where they cannot fill positions. Fortunately, within the Western region, we're at the average at about 28% right now, but that's not sustainable if you think about it. Because within the group of individuals who are working, we also have individuals with their own mental health concerns, their need to care for family. So the number is much greater than that 28% in the Western New York region really dictates, because those individuals, we have a number of individuals out on medical leave right now. They've been on a medical leave. Some of them have been out for 6, 7, 8 months at a time, either caring for family members or caring for themselves. So that really compounds the whole retention issue when you're still trying to fill vacancies, but then you have the current workforce also struggling with a variety of different issues, caring for children, et cetera, which we saw during COVID, and particularly, the team needed to, we were, essential employees, so we needed to be available. And majority of the staff were available, but it was a limited number of staff. And we also lost staff that no longer wanted to work in the field during COVID. So you can see the compounding that occurs when we can't, recruit individuals or individuals who are willing to kind of work in the field and they decide to work elsewhere, or they leave the state altogether. Many individuals worked for us for a number of months and then just decided to move down south or move elsewhere. And so all that time into training and, supporting them gets lost when they're not able to be retained. Again, it is a stepping stone in many respects for people in the mental health field, but usually most people, in my experience, a couple of years, 2 to 3 years, that they would get that before they may go on and maybe pursue a master's degree in social work and move on into other aspects of the mental health system. So I know I've kind of thrown a lot at you in terms of some of the information, but I think one of the things that I've found over the years and is how do we maybe work with the state to look at other incentives to get people to come to work in this field in particular. There are many incentives. When I was supervising social work in another county, which was a comprehensive co-occurring program, they were able to commit to us for 3 years, and their loans were wiped away through underserved region of the state. It'd be wonderful if we had something similar across all aspects of the mental health field. And I think in many respects, people have to work almost 10 years in residential, which is unrealistic. We do have individuals 10, 15, 20, 25 years who have been working direct care, but that's few and far between. So that might be something to explore and look at, as a region, or Western New York region, which, Tompkins is part of that as well. So I don't know if there was any questions. The handout does talk about the different programs in Tompkins County, but if you have specifics about those particular housing programs, I'd be more than happy to answer those for you.
Any questions for David? Okay, well, thank you for that information. We appreciate it.
You're welcome.
Thank you, David. And Elise is going to speak with us. I do want to be cognizant of our time. It's about 6:15, and we are supposed to go into executive session at 6:25. And I do have a few more slides, Elise, to go. So, but I know we can have Elise come back and talk with us further. But there are some specific issues that face cross systems coordination. This was a new goal that was a new need area that was added this year to the plan. And so Elise, with her expertise in this area, is going to share what some of those particular challenges are around cross system coordination. So that's really talking about OMH, OPWDD, and OASIS coming together and coordinating services instead of thinking that a person's only going to get served in one state agency. So take it away, Elise.
Sure, and thank you. I think you've overstated my expertise in this area, but I'll give it a shot anyway. So I think that a lot of the issues that David talked about in relation to what Lakeview is experiencing is pretty reflective of all direct support services and agencies, not only in New York State, but across the country. I think everyone is aware that this crisis existed before COVID, and COVID was just the gasoline on the fire that accelerated the problem now to the point where it is a true crisis. And it's one that I often say is life-threatening for people, especially for some people in the DD system who may need 24-hour support and care with total activities of daily living. So with that said, I think the DD system is constantly, or local service providers at any rate, are constantly searching for solutions. There's been a lot of federal guidance recently around blending, braiding, and sequencing of funds to solve some of these issues. And that's not a new idea. I think, you know, we've been talking about blending and braiding and sequencing services and funding for decades. But I think that now there's probably more of an appetite for it than there has been in the past because there's so much desperation within these systems. I think, 90% of that stemming back to the workforce issues. So in Tompkins County, I think we're down 30 beds for people with developmental disabilities because there's no workforce to staff those houses. So the agencies were forced to close the beds, and they haven't come back. So I think they are more open than ever to looking to partnering with other organizations to see how they can better serve all people with disabilities in the county. And I think one of the issues is that despite the fact that there's definitely a strong appetite in the federal government and, cross-agency guidance around extending flexibilities in different types of funding mechanisms in order to make it easier for that next step of the state agencies have to have the same conversation. So I think we're improving in New York State, but in my observation, that still doesn't happen very much. Even, for example, within NYSED, within the Department of Education, you have on the one hand Access VR, vocational and educational services and for adults. And then on the other hand, you've got P-12 education and the Office of Special Education, and they really exist in pretty strong silos. So there's not even a whole lot of collaboration even within that one department of the state. And then between DD, OMH, and workforce development, I would say that the Department of Labor and the Workforce Development System may be the glue. They are the organization that I think is most invested in reaching out to all the other agencies to make sure that there are opportunities to collaborate and that one knows what the other is doing. And I think one of the things that came up and Sheila, feel free to chime in because I think I missed this meeting, but I think one of the things that came up in the Developmental Disabilities Subcommittee discussion of the goals was that there are often some barriers that exist to coordinated transition services for youth with disabilities that can be unintentionally brought about by participation in the DD system. So again, it's that siloing or that funneling off of individuals as being served by one system or the other to the exclusion of other supports and services that they might be able to avail themselves of. And so I think, the community as a whole would be well served by continue to looking at opportunities to create patchworks of supports and services to help fill in the gaps for one another. I don't see the workforce crisis abating anytime soon because the bottom line is that agencies can do a lot and can try to be really creative and as generous as possible. But until the rate of reimbursement for services is increased, the wages are always going to be substandard for the type of work that is demanded of those positions. So I think that pretty much encapsulates where a lot of the goals that are reflected in this plan stem from. And Sheila, if you have any other insights.
No, I think you summarized it really well.
Okay.
Thank you, Elise. Are there any questions that people have for Elise? All right, I am going to do my best to get through some slides, and then we're going to talk a little bit about those objectives, because I do know that it's important that you can go into executive session. So I'll try and get you as close to that as possible. It's very nice, though. It's a wonderful opportunity to just have people talk about problems with some expertise, and we don't get that often. So time well spent.
Harmony, I think on the agenda, I think that's more time than we need for executive session. So,
Okay.
no, I think if we had 10, 15 minutes, that would be adequate.
Okay, great. Thank you. So we also, we talked a bit about how with the abbreviated planning time for this year, there were a number of questions that were also there were a number of questions being asked, and we didn't really have an opportunity to get as many voices at the table as we wanted. So what we came up with was took all of the needs categories that were in the plan and created a survey and asked board members, subcommittee members, and agency leadership to give us some of their thoughts. Now, that really does give us enough a cross section, albeit small, of our community, and we certainly will look at how we can gather more data for the larger plan. But when we start talking about who's a member of our subcommittees, we do really have a diverse group of people there working in all different levels in agencies and hear different voices. So I feel like we did as best we could in like less than a month, basically, to pull this together. So we had 19 total respondents. 9 of them were agency representatives and 10 were board or subcommittee members. It was interesting to see. I wanted to share this data with you and also can send you the full report. But when you start looking at what board and subcommittee members saw as the biggest priority needs, addiction services seems to be a term that the substance use professionals state agency is starting to use more of, so I'm starting to include that language here. Addiction service priority needs, where prevention services really want to focus on stopping the problem before the problem of addiction starts. Residential treatment services, we're at 58% of those respondents, and then inpatient and outpatient services, 57%. So there was really a focus here on needing to have more services in the substance, just the basic services and supports that our community offers in the addiction field. So that was a little different, I got to say, than maybe some of our discussions. We talked about more about the housing issues and the cross-system coordination issues and things like that, that kind of fell out maybe more broad issues, but there certainly was an expression of need for additional services that are sort of core central services to our community. The mental health priority needs were respite services. A whopping 80% said respite in the mental health system is a significant need in our community. Case management and support, 67%. And interestingly, the category of refugees and immigrants, which was also a new category this year, was not discussed in meetings, came up here. I think people are starting to see that that may be a new area that we should look at in 2024. And we might want to put more of an emphasis on that here. So those were the particular needs that were identified by that particular group. And then developmental disabilities, they only had 2 that really stood out. And you can see by their percentages, like when you're asked, what do you see as the #1 issue? And then, or the top 3 issues, they had two issues that they thought were very important in their transition age services and employment opportunities for people with intellectual and developmental disabilities. And that actually did translate into goals and objectives in our plan this year. When you just look at agency members only, what were the two priorities for them? That there were lots of ideas talked about. There were crisis services mentioned there, but when you look at what were the top two contenders for priority needs, housing for adults and workforce, both for children's services and adult services, were identified by the group of agency leadership that responded. And when you combine everything together, there are so many different categories. We kind of got some different responses. Cross-system coordination took the top percentage there at 94%. People really want to see state agencies, and what, like Elise was saying, like the federal government is really pushing for that, but we need some more work at the state level to make it possible for people. If you're in one system, you don't have to forego other opportunities that might be available to you. Or let's say you get housed through an OMH program, suddenly you're not eligible for any of the other OPWDD services you already had. And today that happens, and it really doesn't make sense because people do need the specialty supports, but they may be able to get another need met from another state agency licensed approved program. So like Elise was saying, we really have to figure out how to bring things together and find some solutions to integrate care so that people get the best service they need. Housing was 90%, and crisis services. So there's been a work on crisis services in the community. But we know we need a more robust crisis model as well. So the other part of the survey focused on health equity. So the work around health equity is being guided by a universal definition and plan, and I believe you have that in front of you as well. This was again from that group from the conference, the state agencies and some volunteer directors of community services. They came up with some universal definitions and a plan of what health equity looks like. So mental hygiene equity is the right to access whole person quality health care and achieve positive outcomes for all populations, regardless of the individual's race, ethnicity, gender identity, gender expression, sexual orientation, socioeconomic status, geographic location, immigration status, language access, and social conditions through prevention and treatment of mental health, substance use disorders, and intellectual developmental disabilities conditions. So that is the definition that they've come up with that they will be using. There are other definitions on racial equity and racial justice that I've included in the paperwork that you have in front of you. So this whole work is beginning with, let's have a universal definition and a plan. And the plan is to focus on racial equity first. We then surveyed the providers to find out information about what, not only what are the priority needs, but where are you in the work around racial equity? And then we talked a bit last time about the OMH Vital Signs Dashboard to collect benchmark data. And that dashboard is public. You can go in there and look at it. And I sent you the link previously, and it drills down based on race, ethnicity, and other factors that we just talked, gender, that we just were talking about now. And you can look at any agency you want in New York State. You can compare agencies in the same county. So it's very detailed information, and it's going to be a good starting place for us to look at goals in the future around health equity. And then we did develop some goals in 2023, and it's really looking forward to that larger 2024 plan. So what did people say in the survey results? The same 19 people, the subcommittee members, board members, and agencies. It's not broken down by who the respondents were. So it's just because you could be a board member and also work at an agency, right? So it was agency respondents, what people thought their agency was doing. So interestingly here you can see, and has your agency started to address racial equity? And if so, how? So over a quarter of agencies that completed the survey said they haven't even started this work. And then at the other end of it, you have over 20% saying they're implementing a plan, with 16% saying that they are doing some of this work, but they didn't feel that their work really fell into any one of those categories. And again, I'll send you out the entire report so you can read all the comments that people wrote when they did the survey as well. I think that's helpful. But we can see clearly there's more work that needs to be done on racial equity. So when asked what on the left-hand side, what racial equity issues impacting children are you most concerned with? I think this is something as a community services board to really take a look at. Is this 58% we're concerned about access to our mental hygiene services, 37% were concerned about children's safety, and 37% around physical health needs. So those were the three priorities that they were seeing for children. And when asked the same question for adults, 53% said housing and 53% said access to quality mental hygiene services, and another 53% said access to just having access to the services and then making sure that those services had the quality to meet the needs of people from minoritized groups. So this information can really help inform our work as we go forward. When asked, what resources do you need to assist in planning efforts to address racial equality? There was local data was one of the options with more accessible demographics. 71% of people felt like that local data would be helpful. Now in OMH, that work that they just did on that dashboard really provides very, very good local data, as well as compared to state rates. So more of that. Training and toolkits, 53% felt that would be helpful. County specific data that comes from the state, which I guess is a better one actually for that new dashboard. And analysis support. So, okay, I have all this data. Now, how do I make sense of it and how do I use it effectively? So that may, result in some need for training in our community and some support in our community and getting further information from the state on how to create accessible information that can help people make good decisions, both at the local level and at the state level. So I will share this information with the conference and the group that worked on creating these questions so that they have some idea of what we're seeing here in Tompkins County, and appreciative of anyone who filled out that survey and gave us that information, because I think it's been very helpful to get a look at where people are at and what we need to do next. So we're getting there. We're getting to our priority needs. We came up with 5 for this year: crisis services, workforce recruitment and retention, housing services, non-clinical supports. We'll go into that in a little bit more depth, and cross-sector services. The non-clinical supports includes work to help support the efforts of expanding and ensuring that peers have the necessary training and support they need across all of the licensed programs, but also there are many peer services that are unlicensed. And how do we sort of wrap our arms around this group and make sure that they have opportunities to speak with each other, to learn from each other, to really have their role be valued and clearly understood by all the different agencies, because there's so many peer jobs. Like, we also don't want their identity to get lost in that work, and make sure that they're getting the supports they need. So that falls under non-clinical. The other is some beginning works toward the health equity and racial equity that we're talking about already in the previous slide. Some objectives towards that. They're under the non-clinical support area as well. So, and a few more things. So we'll get to that in more detail, but these are the broad priority needs. Here are your goals. You also see the goals written down on the sheet that you have in front of you. It should say, here's a need, and there's like a summary description of why was that need identified. And then there's and the next part in the chart shows you the goals. So what are we going to do about these needs? So, and then you'll see all of the objectives and a time frame for them across the chart. So this is good for us. We're down to 5. You had to do 3. You could do up to 10. I think 5 is a really good number when you're trying to do something for a year, and also have to figure out how you're going to make a 4-year plan in the same year. But workforce, we're looking to support the implementation of recruitment and retention strategies by mental hygiene service providers in Tompkins County, as measured by a reduction in vacancies. We had that as measured by a reduction in vacancies last year. So the subcommittees have some ideas on how they can actually learn from membership. What are your vacancies like? Are people at the local level? It gives us at least a snapshot in time if we start to gather some information on what are your vacancies like today? And if we can get agencies to give us that information, it will have us know in real time or pretty close to real time, if that's discussed every month or every quarter or something like that, we'll know where we are in the vacancy world. And do we see improvement? Do we not see improvement? And like Elise said, it's not going to get resolved. And David said it's not. These are huge, huge, multifaceted issues, but at least we can start seeing what it is and also its impact on service delivery. Housing, promote activities to increase the availability of affordable emergency and supportive housing that best meets the needs of individuals who require intensive specialized community-based interventions for stabilization and success across the mental hygiene system, including housing first solutions. So basically, we're saying we need all types of housing in our community. And David, you might have better words for me to use in that description. There might be titles I should have included that I did not include, but we just know that the needs are great and that there's a housing solution for different needs. And you really do need to have all the types of services available to meet everyone's needs successfully and a sufficient amount. Because once you get put on a wait list, you know, if you need housing, you're going to do something. And maybe that means you go in an encampment where you're completely vulnerable, right? And we need to figure out a solution to that. And then crisis services, support the development of a comprehensive crisis services that address the mental hygiene needs. So we have New York State's model is a crisis stabilization center. They want to see that. They want to see a mobile crisis team, and they want to see 988. So we know we're missing one of those three, but also crisis services are not the end all, right? Like you need, what are you going to do to wrap supports around people so they don't continually go in crisis? So how do we build a robust system that addresses people's needs so they're less likely to be in a place of crisis? See, David, I know that because I worked in residential too, right? If you don't solve the problem today, you have a crisis tomorrow. So non-clinical supports recognize the importance of social determinants of health equity, and peer support. So that was the other part about, we know, and you'll see the developmental disabilities group talked about the lack of dental care. And I have an article I found, it was on the front page. I don't know if people saw it on the front page of the paper a few days ago about a new program training dentists to provide care to people with intellectual and developmental disabilities, and trying to say everybody who has a developmental disability needs to be completely knocked out to have any dental work done. They're teaching new techniques and new things like that. So we understand that the determinants of health, whether it's housing or access to dental care or eyeglasses, or primary care or whatever that may be, access to educational opportunities, to vocational opportunities, without looking at the complete picture, we can't possibly serve people to their best. So those are sort of the large goal areas that were driven from our priorities. And then the next piece and last slide is the objectives. You have those in front of you. So you will see, just like last year, we sort of spelled them right out. And my hope is that those are fairly clear to you on what we said we wanted to do, when we wanted to do it. But happy to answer any questions you might have, because that's sort of that's the nitty-gritty meat of the plan that the subcommittees do. And I'll stop sharing. Any questions on the plan or the objectives? Give you a minute. It's a lot of information.
Really appreciate the thoroughness as you planned in such a short timeline. It's you really built the data that drove the goals and objectives, I think.
Thank you. And I got to say, the subcommittees, like when you go and a little nerve wracking to say you got one meeting to put a plan together. Everyone did it. Every subcommittee, like they built that plan. Everything came from them. So they did a phenomenal job with that very little time.
Questions for Harmony?
It's all very interesting.
Yeah. Yeah, and I appreciated having guests speak about some of the on the ground kind of experiences that you've had.
So if you want to take a vote on that, once it's approved, I can submit it to the state and then they will review it and tell us whether or not they agree that it's a good plan.
There a motion to approve this? Tom, a second? Sheila? Any discussion?
What are we voting on?
We're voting to approve this plan and forward it onto the state.
Like the 5 objectives that were just listed?
And
Or
yes, this handout here, yes. Mhm. So do you need a moment, anybody, to ask any more questions? Or okay. So all in favor of approving this? Looks good. Great, approved.
Thank you, everyone.
Thank you for all your hard work.
And I'm sure as we go through the year, we can have people come back and talk about these 5 priority areas to the board as you would like. That you're keeping up to what they're doing and the plan for next year.
Yes, that would be really helpful to put on the front burner there for us. Yeah, great. Okay, thank you.
So
So,
right on time, Mary. It's all you now.
all right. Good. Yeah, so certainly if I did want to mention in Frank's absence, just a comment about the bylaws too, before we go into executive session.
Thanks for coming.
Thank you. In my conversation with him last week, you'll probably recall that we had drafted recommendations for bylaws and we had included in there the recommendation that there not be term limits for our members. So when Frank told me it must have been sometime last week, that the legislature is moving forward with a proposal to have term limits for all of their advisory groups. So that it's probably going to come up for a vote in November sometime. So that is certainly the group that tells us what our bylaws are going to be. So what I was going to suggest, it sounded like there might be a committee hearing later this week to discuss this proposal. And it's obviously not just for our group, it's for any advisory group within the county. But he thought that there'd be a committee meeting where this proposal was going to be discussed later this week sometime. So he had thought it was going to be the 6th, which is Thursday, but I will get more information about that if it is actually the 6th and what time that would be.
Is that the Health and Human Services Committee?
I believe it is. But I was going to also propose that maybe, if people can attend that meeting, that certainly is great. But wondering about writing a letter, just expressing our concerns and how it might impact our group. I think our focus had been on our concern about losing a lot of expertise and institutional knowledge on this group, but also that it could happen very abruptly. So, if they are going forward with something like this, perhaps some kind of transition plan that could be a year out to give us some time to work through whatever the guidelines are going to be. So I wanted your feedback about
Yeah.
something like
I got an email from Stu, and I'm not sure if I'm gonna be available for it. He mentioned October 6th, that's Thursday, right?
right.
So
Yeah.
I don't think I'm going to be available, but I think the idea of having people, be at that meeting, whoever can make it and kind of voice their their concerns. I think the letter is good. I'd also propose that would they be willing to kind of grandfather some people in? Because they'll lose a lot of expertise in this, on our board.
Mhm.
Is the meeting in person or is it
I don't
joined by
know.
YouTube? So you'll be letting us.
Yes, I can. Harmony, do you have an idea of who I can contact to get the specifics of that?
Dan Klein.
I think between Corinne and myself, we can figure it out and get that out to you.
Okay, that'd be great.
Thank you.
Yeah,
Do we
And-
know- sorry,
go
do
ahead.
we know what the proposed term that?
This, I don't think it was definite, but he had heard maybe 2 4-year terms. So how that, how we would deal with all the people who are currently on the board, I'm not sure what their proposal is. So
Do you know what time that they meet?
I don't, yeah. Yeah, so it sounds like with Harmony.
Without information.
Yeah.
Okay, and as Jan asked, if there's a way to do anything virtually or get to speak, that would be, but I can draft a letter then and send it out to all of you in the next day and just see what you
Sure.
think. And so we can at least have that. And then if we have the opportunity to speak directly, I think that would probably be the best we can do at this point.
Definitely, I think at least a transition plan
Mhm.
would make it much smoother.
Yeah, I think it's, however it gets implemented, I think it's going to be disruptive, more or less disruptive, and for the way we've been functioning, and I think, yeah, and I understand the value of term limits in general, but I think there's unique things about different groups that we would want them to consider, so.
Right, I don't, and what would be gained by our board going to term limits? Like, that's what I think I'd be struggling with.
Mhm.
We've had a fair amount of turnover lately.
We've had, yeah.
So
Yeah.
it's not like it's really skewed towards, all people that have been on for a gazillion years.
Yeah.
Maybe.
Right.
Mary, does it also affect the public health board?
I believe so. Yes, it does. Yeah.
They
And-
already had
They have term.
limits. They already
Yeah.
had term limits with.
But I think the proposal would be a general term limit for any advisory board. So there's some differences across boards currently.
Mm.
So,
No, I think some of the motivation behind it is to make sure that marginalized voices have a seat at the table. And when you don't have term limits, then there's not necessarily that churn.
opportunity to,
And so, you tend to have the same voices present forever. But I know that, so on the State Rehab Council, which I chair, we had just a natural large group of folks term out and turn over. A couple of years ago, we brought on 11 new members in 1 year on an advisory board of about 22-ish people. And now that I'm terming off and can't chair, we have a leadership vacuum because we brought on 11 people all at once who were brand new, who don't feel comfortable stepping into any kind of a leadership role. They felt like they were still getting their feet under them on committees and, in terms of the scope of work of the advisory committee. And so that's creating problems now. And that just happened naturally. That wasn't a rule. So I think there's some potential things to think through there as well, that you end up having, if it's too much, too fast.
right.
That's also happening at the New York State Independent Living Council, where a lot of the older term people are terming off. And they have all these people, every position is open for term,
Wow.
because no one feels confident that they can do it when they've only been on like a year.
Yeah, I'll make sure I mention that piece too. We have a leadership part that's
Takes a
helpful.
while. Many of these
Yeah, to
boards are
feel.
kind of complex.
Yeah.
In what they do and how they do it and what's expected. So it's hard until you've been on quite a few years to really get it all.
Especially if there's any kind of a regulatory component, like you, not that you would regulate, but that you have to understand regulations.
Uh-huh.
You know, that can take a really long time, like a period of years for people
Sure.
to sort of build their understanding.
Mhm.
But one thing about the SRC is they have a rule that if you step away for 1 year, you can apply to come back. So
Okay.
that's sort of a good workaround. And we have had that happen where people who were just really connected and really invested in the work, take a year off and then come back.
Okay. All right.
I can add, since conversation is happening and whether it happens or not, perhaps, and I don't know if this already happens, but if there's like, an opportunity, I don't know if like the vice or other officers, I guess it would be the same term, but just, you know, where someone can kind of, like shadow and just learn more, or if there's other opportunities, because it is hard, you know, when you're only once a month for like an hour and a half, you're really just listening to what's happening, but you don't know the stuff on the back end. And so when that's happening, you're gonna have a million questions, just like starting a new job. And so I think if there's an opportunity for whether, you know, it's a handbook, you know, or an opportunity to just, you know, have conversation with officers where officers kind of talk about, this is what we do, and just share it to the board, maybe once a quarter or, you know,
Oh,
once a
good
term.
idea.
So that way
Mhm.
officers are like, you know, well, maybe I'm good at that. I could probably see that, but just kind of like
Yeah,
having that conversation early.
yeah, if you know more about what's involved, and that's true. Yeah, that's a good point.
So the legislature meets this Thursday, October 6th at 5:30. And Health and Human Services, they meet on October 17th at 3 p.m.
Oh, the 17th.
Yeah,
Okay,
At what time? I'm sorry.
3 p.m.
3 p.m.
3 p.m.
Is that the one we're supposed to?
And we think that is Harmony, is that the one that
I-
we should be?
I think because the legislature is meeting on the 6th,
Yeah,
that's the one where they're gonna make the decision of the term limits.
Yeah.
And that's why I think we need to voice our opinion, right, Harmony?
I think so, but I want to confirm it with Frank and then we can send you out an email.
okay, that'd be
just so
great.
we Make sure, and then we need to find out the virtual question too.
So the 6th or the 17th, we'll get more information.
I'm looking at their website, so
Okay,
that's what they're saying, so.
That's what they're saying. Okay.
Yeah, the 6th is the legislature, the regular meeting, and they'll probably discuss the term limits. And on the 17th is Health and Human Services, which is 17th at 3 o'clock.
okay.
If you guys can hear me? Yes, no?
Yes.
Yes,
Yeah.
yes.
At the last board meeting, if I remember, Frank was suggesting that if we had come to the meeting on the 6th, which I hear is 5:30, that would be more strategic than, you know, waiting for the 17th. On the 6th is the discussion of should we have term limits or not. And I think majority of the legislators want term limits. However, I believe they don't have a good understanding of how our board works. And it's been mentioned that it takes a long time to know what you're doing on the board and activisms and so forth. In fact, Sally Mae idea of a handbook was introduced, I guess, many years ago, and we've had such things as board retreats for a variety of purposes. One, to figure out how the system works and share that information, because we rarely as a board meet to discuss how things work. So I think we had a couple of retreats to discuss how to deal with state issues, how the board can get things done. And to my recollection, we haven't had that in quite a while. And, to make the point of if we suddenly had term limits, it'd be at least 6, maybe 7 board members that would be eliminated from the board. And being on the nominating committee for a number of years, I find, I think Mary and Jan can back me up, that the last 3 years, particularly with COVID, that it's been extremely difficult to find folks for not just the committees, but on the board. I mean, we're still down folks, and to eliminate half the board for the sole purpose of limiting term limits, I think we need to communicate with the state legislators to perhaps convince them why it's especially important for us not to have the term limits. And I did send an email out to a couple of folks about that. And when I spoke with Frank, he thought it would be a good idea. He knew I would be out of town for that meeting. So to either have the board write something up and send it. I understand that, I reached out to Sheila just today and she's not going to be able to do it as well. But some presence in the room from the board, I think, would be helpful. If not, a letter, a statement of why we think it's important for us not to have term limits. So I think that Thursday meeting, the 6th, is probably the important time to get our message across. I certainly be willing to write up some of my opinions and send it to the board and then have it okayed by you all, and perhaps have it read by somebody who can attend, or if it's, what did we write? I wrote down it's 5:30, so that's 2:30 my time. I certainly can get onto Zoom and present it myself, but I think it might be more effective if somebody was there in person. So
Well, I think I'm certainly willing to write it for the board, but I think having more than one letter as members is certainly fine too. And if you know specific legislators that who will be voting on this, you may want to advocate in that way too. That's definitely possible. I'm really aware of the time here, and we need to act on a couple of applications. So do you feel like we have enough of a plan? I think we're going to get a confirmation from Harmony about the time and where we should be. And I will send a draft of a letter out to all of you. And if I can make these meetings, I will certainly go. But if some of you plan on coming, let me know and we can coordinate and make sure that we're on the same page and acting in a united way here.
Yeah, and I assume that it would be during the public comment period where we would, and that tends to be right at the very beginning.
Uh-huh.
Yeah, so if that's the case, I might be able to come for a very short, for that
Okay.
very short time.
And
Okay.
sometimes,
Another commitment at 6:30, so.
and if
Yeah.
Harmony can give us, if there's any instructions about signing up to talk, to speak during public comment, because I know for the city, you have to sign up in the morning and.
Okay.
I think, yeah, my understanding, and unless it's changed, I think we can just sign up right when you enter, you can just.
Yeah, we've
yeah,
done that.
yeah.
Yes. Mm. So,
If you're in person, you mean?
yeah, that's true. But if there is a virtual option, it may be different.
Oh, yeah,
I don't know.
Yeah.
I'm just familiar with the city rules at this particular time.
yeah, yeah. So maybe we get some clarification on that as well.
Okay. All right. So more to come on this then, and we'll do what we can and make our case for how we want to work here.
I have a motion that we go into executive session.
Spelling, okay, in a second. Sheila. All right, so going into executive session, do we have to stop recording here?
Yes.
Yes, I'm gonna stop recording and I think we can end Zoom. Well, no, Stu, you're staying on for executive session. Okay, so I will just stop the recording. Thank you, everyone.
Okay, thank you.